Neurology quiz number 123. Describe the etiology, clinical features, investigation, and treatment of giant cell arteritis or GCA. GCA, also known as temporal arteritis or Horton's disease, is the most common systemic vasculitis in adults aged more than 50 years. It is characterized by granulomatous inflammation of the large and medium-sized arteries, especially the extracranial branches of the carotid artery and the aorta. Epidemiology and risk factors. Annual incidence is 1 in 44 per 100,000 persons more than 50. Strong female predominance, most common in Northern European ancestry, rare in Asian or African populations. Risk factors include older age, smoking, and early menopause. There is a genetic predisposition to with the following HLA alleles. Immunopathogenesis. Disease begins in the adventitia with activation of the dendritic cells. They recruit CD4 T cells, which in turn activate neutrophils and activate macrophages. Cytokines lead to granulomatous inflammation, elastic lamina fragmentation, intimal hyperplasia, and luminal occlusion with ischemia. Some macrophages fuse to form multinucleated giant cells, giving the disease its name. Environmental triggers such as varicella zoster virus have been proposed but remain unconfirmed. Clinical spectrum and phenotypes. Cranial GCA or classic form, large vessel GCA, polymyalgia rheumatica or PMR. These can overlap. Cranial GCA affects the extracranial branches of the carotid artery, most notably the superficial temporal, occipital, ophthalmic, posterior ciliary, and maxillary arteries. Clinical features: a headache in 70 to 90%, typically new onset, localized to the temporal or occipital region, and scalp tenderness is common. The affected artery may be thickened, tender, or nodular on palpation, and pulsation may be absent. This picture shows the arteries involved in cranial GCA. Ophthalmic manifestations. Ischemia of branches of the ophthalmic artery and the posterior ciliary arteries leads to the characteristic ocular complications. Transient visual obscurations or amaurosis fugax is an early warning sign. Permanent visual loss due to anterior ischemic optic neuropathy or AION is the most dreaded complication due to involvement of the short posterior ciliary arteries. Fundoscopy typically shows a pale and swollen optic disc with splinter hemorrhages. Less commonly, central retinal artery occlusion, ophthalmoplegia or diplopia due to ischemia of cranial nerves 3, 4, or 6. Visual symptoms are often monocular initially, but can become bilateral within days if untreated. AION in GCA is due to involvement of the short posterior ciliary arteries, and these arise from the ophthalmic artery and supply the optic nerve head, as is shown in the figure. Other features include jaw claudication due to ischemic pain in the masseter muscle with chewing, which is highly specific, and due to maxillary artery involvement. Tongue claudication or necrosis can occur due to lingual artery involvement. And then neurological ischemic complications. Stroke, especially vertebrobasilar or carotid territory, occurs in 3 to 7% of the cases. Risk is higher in untreated disease. Transient ischemic attacks, especially in the posterior circulation. Peripheral neuropathies are rare but can occur due to vasa nervorum involvement. Systemic symptoms, as described below under large vessel GCA. These figures show some of the clinical features. In A, a thickened and palpable superficial temporal artery. In B, a pale and swollen optic nerve head. And in C, an ulcerated left side of the tongue. Large vessel GCA affects aorta, subclavian, and axillary and carotid arteries. It has constitutional symptoms in the form of fever, malaise, fatigue, and weight loss. High fevers may occur. Vascular symptoms include limb claudication, carotidynia, asymmetric pulses, and aortic pain. Aortic aneurysm or dissection develops in 10 to 20%. And number 3 is polymyalgia rheumatica, or PMR overlap, seen in 40 to 60% of the cases. Conversely, 20% of PMR evolves into GCA. It is characterized by symmetrical pain and stiffness in the shoulders, hips, with morning limitation, and this improves with activity. Bursitis and tenosynovitis is seen on imaging. It responds dramatically to low-dose steroids. This figure on the left shows arteries involved in large vessel GCA, and on the right shows common points of pain and tenderness in PMR. Diagnosis, lab findings, ESR more than 50 millimeters per hour and CRP is elevated in more than 95%, though up to 5 to 10% may have normal results. Combined testing increases sensitivity. Imaging modalities, ultrasound. This is now the first line per EULAR guidelines. Sensitivity is 70 to 80% for cranial GCA. Specificity is 90 to 100% when both halo and compression signs are present. Bilateral halos have near pathognomonic value. Ultrasound findings, halo sign, this is best performed within 4 days after steroids started, as steroids can cause it to disappear. Seen in the temporal arteries, especially frontal and parietal branches, occasionally in the facial or occipital arteries, as well as axillary and subclavian arteries in the large vessel type. It appears as a dark or hypoechoic ring around the lumen, which is sharply demarcated from the surrounding tissues and corresponds to thickening of the intima in the media of the blood vessel. B. Compression sign refers to persistence of the hypoechoic halo despite luminal compression by the ultrasound probe. The sonographer applies gentle probe pressure over the artery and the lumen collapses completely in normals. In GCA, the arterial wall is stiff and thickened, and so the lumen remains partially open and the hypoechoic halo persists, and this is called a positive compression sign. Other findings include elevated flow velocity and spectral broadening due to luminal narrowing. This figure in A shows the typical halo sign of the superficial temporal artery. This is a transverse scan, and a hypoechoic rim is seen around the vessel lumen. In B is a superficial temporal artery longitudinal view showing circumferential hypoechoic wall thickening. FDG PET-CT detects large vessel inflammation but is less sensitive for cranial arteries. Temporal artery biopsy, this remains the gold standard. Sensitivity is 60 to 87% and specificity is 100%. False negatives occur due to skipped lesions or prior steroid therapy. It should be performed within 1 to 2 weeks of steroid initiation, although there are reports that yield can persist up to 4 weeks. Pathology shows transmural granulomatous arteritis or panarteritis with lymphocytes, macrophages, and giant cells, and internal elastic laminar disruption. Skip lesions can occur leading to false negatives in up to 40%. Bilateral biopsies increase the yield by 5 to 10%. This figure in A shows a thickened and pale superficial temporal artery prior to biopsy, and in B shows an STA biopsy showing transmural granulomatous inflammation with intimal hyperplasia and severe luminal narrowing. In C is an STA biopsy, high magnification, showing multinucleated giant cells as indicated by the arrowheads. Treatment and management. Glucocorticoids are first-line therapy. If there is no visual loss, prednisone 40 to 60 milligrams per day for 2 to 4 weeks, then taper. If there is visual loss or stroke, IV methylprednisolone 500 to 1000 milligrams per day for 3 days, followed by oral steroid taper. For PMR overlap, prednisone 15 to 25 milligrams per day. Gradual reduction of oral prednisone to less than 5 milligrams per day by 12 to 18 months. Rapid taper in less than 6 months increases relapse risk. Monitor ESR and CRP and symptoms as steroids are being tapered. Relapse management. Relapse occurs in 34 to 75% of patients, often within the first year, and at prednisone doses of less than 20 milligrams per day. Symptoms include headache, limb ischemia, jaw claudication, and PMR symptoms. Treatment is increased prednisone to 30 to 60 milligrams if GCA relapse or 5 to 10 milligrams if PMR symptoms. Steroid-sparing agents such as methotrexate, azathioprine, leflunomide, and cyclophosphamide can be beneficial. Tocilizumab, which is an IL-6 inhibitor, it is proven in randomized trials and markedly reduces relapse and steroid requirements. Dosing is 162 milligrams subcutaneously weekly or 8 milligrams per kilogram IV monthly. Risks include GI perforation. Effectiveness in preventing blindness is uncertain, and optic neuropathy still occurred in some cases. Long-term safety data are limited, and current guidelines suggest limiting use to 1 year until further data. It is not yet included in various guidelines as a first-line drug. Prognosis and long-term monitoring. Relapses occur in more than 50% of patients, especially those with large vessel involvement or high initial inflammatory markers. Aortic aneurysm develops in 10 to 20%, typically thoracic, and periodic imaging every 2 to 5 years is advised. Early treatment prevents blindness, but once vision loss occurs, recovery is rare. Even in remission, vascular remodeling and stenosis can progress, which is called smoldering GCA. Mortality is 1 to 3%. And mainly vascular from aortic aneurysm or dissection. This figure shows the ACR and the EULAR criteria for classification of giant cell arteritis.